Welcome to Bioethics Grand Rounds, brought to you by the Center for Bioethics and Social Sciences and Medicine. I'm Christian Verkler, the co-chief of the Clinical Ethics Service, and it gives me great pleasure to introduce Ryan Antiel to you. Ryan is currently at the Mayo Clinic. Ryan's a Midwesterner. He grew up around the Minneapolis area and then went to Taylor for undergrad, which is in Indiana, and then got his master's in theological studies at Wheaton College, which is also where I studied theological studies. And then he went on to the Mayo Clinic to do his medical degree. During that time, he was lucky enough to get to be the Edmund Pellegrino pre-doctoral fellowship. So he spent a summer reading books with Edmund Pellegrino, which is a pretty enviable fellowship, I'd say. He completed his MD at Mayo and then has been there ever since in surgery residency. He took a 2-year hiatus to go to Penn, where he got his master's degree in bioethics there as well, while he was doing basic science research on some of the things that he's going to talk to you about today. When I checked last night, PubMed said Ryan had 59 publications. Maybe some more have come out since I checked. But he's still a chief resident in general surgery, so that's pretty impressive. And we're really lucky to be able to have him to come down here from the Mayo Clinic to give us a talk today on clinical innovations near the boundary of viability, the artificial placenta. So join me in welcoming Ryan.
Good afternoon. Thanks so much for having me. It's a real privilege to be with you. When Christian and I were talking about topics of interest to me and a topic that would be interesting to your group, obviously, the artificial placenta immediately came to mind as some phenomenal work's being done here in Ann Arbor on this topic. So I look forward to presenting a little bit about the technology itself, some ethical, societal challenges with it, and I'll leave plenty of time for discussion. This is Renee. She's an otherwise healthy 27-year-old pregnant female, G1P0. In Renee's second trimester, she woke up when her water broke. She immediately called her obstetrician. At the time, she was 22 weeks and 5 days pregnant. Pregnancy really had been uneventful up to this point. She had a little morning sickness the first month or two, but otherwise had been doing well. At 20 weeks, she got a fetal ultrasound, which showed normal growth, no anatomic abnormalities. The triage nurse told Renee that she should report immediately to the obstetric triage unit at the hospital, which she did. They examined her when she got there, and sure enough, she had a pooling of fluid, pH of which was consistent with amniotic fluid. Ultrasound was performed, which confirmed that Renee's amniotic sac had ruptured and had what was called oligohydramnios, not enough fluid in the sac at this point. So she got admitted to the hospital for expected management. So over the next 24 hours, Renee met not only with the obstetric staff, but with neonatologists, with a pediatric surgeon. Given that she was extremely premature at this time, if her fetus or baby were to survive, that child would have significant comorbidities, potentially lifelong neurodevelopment disabilities. So Renee was given 3 options to consider. The first was, if she was to go into labor, she could simply proceed with palliative care for the infant, comfort care, palliative care. The other option was that she could choose for her baby to undergo resuscitation and intensive care. This would probably include intubation, mechanical ventilation, support of the child's multiple organ systems. And a third option presented to Renee was that she could take part in a research study for an extracorporeal system, an artificial womb. The fetus would be delivered through a procedure similar to a C-section, a hysterotomy, where the placenta was not detached until the umbilical cord was cannulized. This would provide nutrition, oxygen to the baby, remove carbon dioxide. The neonate would be placed in a clear plastic bag filled with synthetic amniotic fluid. The device, the researchers told her, had been tested with very promising results in lambs, and their daughter would be one of the first humans to undergo testing on this artificial placenta. So given the poor prognosis, Renee and her husband thought about this and decided to enroll in the trial. So 2 days later, at 23 weeks and 1 day gestation, Renee underwent the exit procedure and her daughter was placed on the artificial placenta. Now this, perhaps 10 years ago, might have sounded like science fiction, and although this patient account is fictitious, a trial like this very well may be happening here in Michigan and other places across the country in the next couple of years. Now, the greatest risk factor for any infant in terms of mortality is prematurity. And the US, interestingly enough, has the highest rate of prematurity among any industrialized nation, just over 10%. So beyond the risk of mortality with prematurity, pretty much every body system of the child is at risk. Respiratory distress, cardiovascular disease, intestinal injury, immunological compromise, hearing vision problems, neurological insult. Health economists have estimated that in the United States, we spend an estimated $26 billion a year on prematurity. So there's obviously an urgent and important need to better support these neonates. Now, the most common problem for these extremely premature neonates is respiratory failure. The extremely premature neonate has insufficient lung development, maturation to permit normal gas exchange necessary to sustain life. Now, for those of you in neonatal medicine in the audience, you know that during the 1980s through the 1990s, there's been incredible advancement in the treatment of immature lungs. Things such as antenatal steroid administration, artificial surfactant, vasodilatory therapies, ventilating strategies like high-frequency oscillators. And when these conventional treatments fail, the next step is ECMO, which was first developed here in Ann Arbor. It uses a heart-lung bypass machine to continually remove blood from the patient, filtering out carbon dioxide, and then oxygenating the blood before returning it to the patient. The problem is that ECMO is not an option for premature infants. Depending on the institution, most places will not consider ECMO unless you're about 34 weeks or about 2,000 grams. Patients need to be on systemic heparinization when they're on ECMO therapy, and this can lead to a lot of issues for a premature infant, such as brain bleeds, intracranial bleeding. So all of these limitations have really been the impetus, so to speak, for the development of an extrauterine system to better bridge the fetal life to the postnatal life. As Christian mentioned, I had the opportunity to spend a couple years in Philadelphia. And when I was there, worked closely with one of the fetal and pediatric surgeons, Dr. Flake. So I'm most familiar with the work that Dr. Flake, as well as Emily Partridge, had done in regards to the artificial placenta. When I was in Philadelphia, Emily's paper was published in Nature Communications, where she demonstrated the use of this in their laboratory using a LAM system. It's a pumpless design system. The lambs are attached to this pump, and the lamb's own heart is driving the exchange of blood. As you can see, there's an oxygenator, which gives oxygen to the fetus and then removes carbon dioxide. In addition, in this model, the lamb is surrounded by synthetic amniotic fluid with the different electrolytes appropriate for that gestational age, and a pump is used to move that in and out of this bag. After cannulation, this bag is sealed, preventing or hopefully decreasing the risk of infections. And you can both see through the bag. It's translucent, so you can observe the fetus, and it's also sonolucent, so you can use ultrasound. There's different watertight ports to accommodate cannulas, temperature probes to monitor the fetus. This particular design uses a heparin-coated components, minimal circuit surface, so you don't need to heparinize the lambs. So in Dr. Flake's laboratory, these lambs have been supported on this device for up to 4 weeks. Lambs were equivalent physiologically to a premature infant. Here's just a short video of the lambs kind of moving around while attached to this device. The lambs had normal gas exchange, oxygen delivery, nutrition, growth, neurodevelopment. And the laboratory is currently working with the FDA to move this to clinical trial in the next year or two. Now, the reaction to this work, as well as work done here at University of Michigan and other places, has been largely positive. However, several individuals have raised social ethical concerns about using this sort of technology in humans. Now, while some of these concerns have been grounded in distorted facts, misunderstandings, others have raised very important issues. So the purpose of this talk this morning is to provide, in essence, a brief response to three of the most common objections raised in the popular press. Shortly after Emily published her work in Nature Communications, NPR ran an article reporting both the outcomes, and interestingly enough, the response to it was largely that of bioethical concerns. So they had many prominent bioethicists kind of weigh in on their thoughts on the topic. So I'm going to select some of the arguments that those individuals, or cautions rather, that those individuals raised, and give a short response to that. I became interested, obviously, in this technology working with Dr. Flake and some others at Penn. We had the opportunity to work together to actually co-author a chapter on this topic, which is going to be coming out this fall in Eric Kodish and Robert Nelson's second edition of Ethics and Research with Children, published by Oxford Press. A few disclosures, though, as I kind of launch into our discussion. First of all, I have no financial conflicts of interest. I'm not involved in the patents or in any way benefit from this technology. Also, I had no involvement in the development or testing of the artificial placenta, so my research interests are largely in the social sciences and clinical ethics. I did not work in Dr. Flake's lab specifically. I've worked with him, but not on this model itself, and I think that's important. And although I've worked closely with many of the folks that have worked on this, including that chapter in which I'm drawing a lot of material from, this morning's talk is my own, not the opinions of Dr. Flake or the Mayo Clinic or the Children's Hospital of Philadelphia. And finally, I'm not the right person to launch into lengthy discussion about the physiology and the biology of this technology. There's experts in the audience who could do a much better job than myself at that. Instead, I just want to use the little bit of time that we have to focus more using this technology as really a lens to examine some of the social and ethical considerations in the care for premature infants. So the first objection that folks have raised, that this device may prevent babies from dying, but will likely result in babies being born with severe morbidities. So if this is true, appropriate question to ask would be, should we save these lives in the first place? Philosopher Diana Davis says no. She writes, if there's a difference between a baby dying rather peacefully and a baby dying under conditions of great stress and discomfort, then no, I don't think it's better. Physician and poet Lewis Thomas coined the term many years ago, halfway technologies, to describe many of the new technologies that he saw being introduced back in the 1950s, an example of which was the iron lung for the treatment of polio. Now, what he meant by this description, halfway technology, was that many of these new treatments that he saw being introduced only halfway or partially worked. They might save lives, but they left patients in health states that many might consider not truly living. So for example, as I mentioned, the iron lung to treat polio was at the same time highly sophisticated and profoundly primitive. And this phenomenon certainly exists in neonatal medicine and surgery today. Some parents, physicians, are inclined to use medicine to preserve what I call bare biological life, and at any cost, while others will focus on quality of life, arguing that aggressive, extraordinary treatments leads to more pain, more suffering. Both approaches has the potential to be problematic. So for example, on the one hand, a life at all cost approach, utilizing any technology available to preserve bare life, even when the chances of survival are low and the chances of severe disability are high, can result in undue and unnecessary suffering. Many of us are aware when parents or physician teams have neonates undergo multiple procedures, multiple invasive surgeries, intensive care to simply support physiological functioning, merely delaying death. Pediatrician and ethicist at Kansas City, John Lantos, has commented on this tragedy. He writes, "If we treat every baby until we're 100% certain that the baby will die, we may occasionally save a baby who would otherwise not have died. But treating every baby until we know they will die would lead to more neonatal and parental pain and suffering." On the other hand, there's those who prioritize projected quality of life. And these individuals might choose to discontinue life-sustaining technologies based on information or misinformation, rather, about what life with a disability is actually like. Their calculations might be based on inaccurate data. There was a really fascinating study that came out about 5 years ago that looked at parents of children with spina bifida and their pediatricians. And they asked both the parents to describe the quality of life that their child and the family had, and then they asked the pediatrician to guesstimate what that quality of life was like. And as probably many of you can imagine, the physicians are quite poor at predicting actual quality of life that these families reported. So patients, parents have incredible adaptability, incredible resistance when confronted with disability, making this a daunting task for parents, physicians to decide when to stop life-sustaining treatment. Now, in regards to Dr. Davis's concern, I believe that it is applicable in certain contexts of the artificial placenta. However, the animal data, both out of Philadelphia as well as out of Michigan, demonstrates that not only do these animals survive, but they also do not suffer the common morbidities associated with prematurity. These animals have shown normal growth, lung maturation, and brain development. So obviously, while it remains to be tested in humans, these data at least offer hope at this time that this technology will not simply improve survival, but will diminish the current morbidities of prematurity. Furthermore, the proposed artificial placenta, the extracorporeal support system, will be tested on neonates aged 23 weeks or older. And this is a really important point, and we'll talk about this a little more. But this group of infants already has a fairly high survival rate. So this group that has a high survival rate and a high morbidity rate, if in fact this technology proves to be successful, would simply and hopefully diminish those morbidities associated with prematurity. In essence, it might mitigate this halfway technology of current neonatal medicine. Now, I do believe that Dr. Davis's concern will become relevant in the future if the technology is able to be applied to younger and younger fetuses, who may not get the same morbidity benefits of their younger counterparts. Therefore, I would urge caution in applying this technology to neonates younger than 23 weeks at this time until we better understand the morbidities in this younger population. Objection 2, the device will challenge our abortion politics. So Davis also argues that the artificial placenta, the extrauterine support, will have ramifications on abortion politics. So this concern really hinges on the concept of viability. In both the United Kingdom and obviously here in the States, a woman's right to terminate her pregnancy ends when the fetus becomes viable. In 1967, the British Parliament passed the Abortion Act, and at that time, not all terminations in the United Kingdom were legal. They relied on earlier piece of legislation, the Infant Life Preservation Act of 1929, where the Parliament argued that only legalizing termination of non-viable fetuses was permitted. And similarly, in the landmark U.S. case, Roe versus Wade, 1973, viability was chosen as the dividing line. But one quickly sees that the premise of grounding this threshold on viability as problematic as the right to terminate or the right to life, whichever way you want to look at it, becomes contingent on the state of current medical technology and access to that technology. Now, it's again important that I emphasize that Dr. Flake and others have indicated that this technology will only be used on fetuses 23 weeks and older. So the question of viability, at least at this time, is not being challenged, but it's not implausible to imagine a time when the technology is able to support fetuses earlier and earlier, pushing back the limits of viability. So why should viability be the ultimate criterion? I argue that the problem with our legal standard is, first, technology makes viability a constantly moving target. And second, the required aid for the preservation of life in a neonatal intensive care unit is so significant that it renders the notion of autonomous existence meaningless, in my opinion. Justice Sandra Day O'Connor astutely noted this when she wrote regarding the analytical framework of Roe versus Wade, that it is, quote, clearly on a collision course with itself, unquote. Those medical technologies continue to advance, it may be necessary to reconsider the basis of our termination laws. It's clearly well beyond the scope of this talk to propose alternative thresholds to viability, but Davis's point with these rising technologies is certainly understood. Now, a related and perhaps more germane concern is the potential for coercive use of this technology. So philosopher Scott Gelfand believes that the state could theoretically require a pregnant woman who is seeking an abortion to instead put the fetus on an extrauterine device. The transition from uterine to extrauterine life would require, as I mentioned earlier, the fetus to be delivered through what's known as an exit procedure, which is similar to cesarean section, while just leaving the placenta attached to the uterus until the fetus can be cannulated. In order to place a fetus on this device against a woman's wishes, the pregnant woman would be forced to undergo, in essence, a cesarean section. This controversy is not unsimilar to contentious debates about compulsory treatment when a pregnant woman refuses to undergo a cesarean delivery for fetal distress, as an example. Now, the American College of Obstetrics and Gynecology Committee on Ethics has argued very, very strongly against the use of any coercive means, even in these difficult situations. And regarding the use of force around maternal fetal surgery, there was recently a joint statement both by the American Academy of Pediatrics and the American College of Obstetrics and Gynecology, in which they argue that even the strongest evidence for fetal benefit would not be sufficient ethically to ever override a pregnant woman's decision to forgo fetal treatment. And I think the vast majority of physicians and ethicists would agree that forcing a woman to undergo surgery, even a surgery that could potentially have great benefit to the fetus, is never justifiable. The third objection is that the device represents the ultimate technological transformation of pregnancy. Now, certainly pregnancy has undergone enormous technological transformations over the past several decades. Common technologies include radiological diagnostics, ultrasound, MRIs. You can think of in vitro fertilization, fetal genetic diagnostics, maternal fetal surgery for conditions ranging from anemia to spina bifida, to advanced monitoring during labor. Yet critics believe that the extrauterine system, or the artificial placenta, would transform pregnancy to an even greater extent, ultimately separating women from pregnancy. Davis imagines a world that looks like science fiction, and she cites Huxley's Brave New World. If you remember in the opening chapters of Huxley's novel, he writes, "One by one, the eggs were transferred from their test tubes to the larger containers, and there, in crimson darkness, stewing warm on their cushion of peritoneum, gorged with blood surrogate and hormones, the fetuses grew and grew." through the weeks until in the decanting room, the newly unbottled babes uttered their first yell of horror and amazement. So these concerns ultimately regard what a British scientist by the name of J.B.S. Haldane termed back in 1924 ectogenesis, a complete separation or divesting of women and reproduction. Sociologist Barbara Katz-Rothman argued that this technology, the artificial placenta, could have the problem that raising a baby in a machine, she argues, is ultimately denied a human connection. Now, ectogenesis, really separating pregnancy, reproduction from the female body, would certainly benefit women who desired a biologically related child, but were otherwise unable to have a child outside of IVF and surrogacy, or perhaps uterine transplantation. So this would include women with recurrent miscarriages, would include women who've had hysterectomies for very common reasons, fibroids, endometriosis, gynecologic cancer. So beyond the benefits for women with these medical conditions, some feminist scholars believe that ectogenesis would ultimately liberate women from an oppressive patriarchal society that they believe is rooted in the fact of unequal bearing of reproduction. Other feminists, though, have been more skeptical. They've taken a more nuanced or calculated response to this topic. For example, bioethicist Rosemary Tong writes that artificial wombs may commodify pregnancy, disrupt the meaning of the mother-child relationship, and lead us to view the growing child as a thing. Philosopher Julian Murphy argues that ectogenesis is a sexist paradigm that could actually contribute to women's oppression. While the technology may be promoted as an attempt to abolish sexism, ectogenesis reduces a woman's role in pregnancy. What women contribute to their pregnancy is not essential to reproduction. Yet a woman's role in pregnancy is far from stagnant. Philosopher Hilda Lindemann, in her 2014 book, argues along similar lines when she writes that pregnancy isn't something that merely happens to a woman, it's something that she does. Lindemann borrows from Marx's famous distinction between an architect and a bee to show how society's view of pregnancy as passive, uncreative, like a bee, is false. Instead, Lindemann argues, the woman is an architect in essence. Listen to what she writes. In non-human animals, for all we can tell, pregnancy is the process that occurs in the female without any purposeful contribution on her part. She passively suffers the fetus to grow in her rather than actively shaping it. So the relationship that ensues is purely biological. In human pregnancies, by contrast, what begins as a purely biological relationship is transformed into a recognizably human one because by what the woman does in word, deed, and imagination, she calls her fetus into personhood. Janet D. Petreo, she's the director of Johns Hopkins Fetal Neurodevelopment Project, argues that the maternal context provides an environment that goes far beyond simply a circulatory system connection. Maternal hormones, heart rate, blood pressure, bowel sounds, all influence not only fetal growth, development, but have even been shown to transform the various genetic expression of the fetus. So while deliberations over ectogenesis are intellectually stimulating, perhaps, in a bioethics classroom, I believe that it ultimately remains a pipe dream at this time. The current technology is far from total replacement of the maternal-fetal connection, given significant technological limitations. There's an enormous gap between a 14-day-old embryo, and U.S. laws prohibit human embryo experimentation past 14 days. But there's an enormous gap between that 14-day-old embryo and a 23-week-old fetus. The early embryo relies on diffusion for oxygen and for other nutrients. But eventually, early embryogenesis is restricted. Diffusion's not enough. You surpass its limitations. At that point, the embryo needs a much more substantial maternal connection. The embryo needs a rich vascular uterus, the placenta, and the umbilical cord. So in conclusion, the recently published data, both out of Philadelphia and here in Ann Arbor, is exciting. It reports that the extracorporeal support of premature fetal lambs has significantly been shown in their model to ameliorate the significant morbidities of prematurity. Now, in order for the fields of neonatal surgery and medicine to continue to advance and to expand, obviously new efforts in innovation and research are necessary. The philosophers I quoted and the ethicists I quoted raise, however, important social and ethical considerations, which all the scientists and physicians working in this area must take note of. However, I hypothesize that similar to the lambs, the data on the fetal lambs, this technology will decrease morbidity for the human neonates born after 23 weeks. I reaffirm that it's never justifiable to force a pregnant woman to undergo surgery to benefit her fetus. And finally, I acknowledge the critical physiological and social connection between a pregnant woman and her fetus. This extrauterine device, the artificial placenta, does not replace this essential connection. Instead, it is a therapy to support neonates when the maternal-fetal connection is disrupted by a premature labor. Thank you so much for your attention. I've left about 20 minutes or so, so I hope we can have a good discussion going forward. Thank you.
That was a great, I think, well. I guess my concern, so we've been doing artificial lab model, different. Started 10 years, started they, at the advances they made in the animal model, like substantial in preventing umbilical vessel spasm. And so I think their work is in the animal model is really great and it's corroborated a lot of the work that we've done here. I have very strong concerns, and I'd love for you to address these. I believe clinical translation is not possible with their artificial precisely for ethical reasons. And I'll enumerate what I mean by that. So the first thing is that you need to have an exit, which is a maternal fetal intervention. So now you're addressing two patients. And so the potential morbidity of an exit procedure at an early gestational age is substantial. So now that introduces maternal morbidity into the equation for an unproven technology. And furthermore, at that gestational age, the lower uterine segment is not developed, so you have to do a classical C-section. So that has implications on the maternal side for future pregnancy. The third issue is that premature birth is often specific. So you can't, get a whole fetal surgery team ready to do this. And then on the fetal side, the major concern I would have is apart from gestational age, you have absolutely no risk stratification. So for the neonatologists in the room, they know there are some 24-weekers who have grown up to be medical students. I don't know if that means they were successful, but depends on but there's no risk stratification. So if you're huge ethical concerns in that mode of clinical translation. The artificial placenta that we've developed here is intended as a rescue therapy. So it's intended after a baby's born, and then you can risk stratify to see how they're doing. And if they're failing, you can then transition them to the artificial placenta and recreate many aspects of intrauterine life.
Yeah, thank you so much for those comments. Very helpful. In the realm of maternal fetal surgery in general, obviously there's been enormous debate about to what risks ought or should a woman even be permitted to take in order to potentially benefit her fetus. Obviously, the more minimal risk, for example, ultrasound-guided needle injections for something like fetal anemia, not a lot of people have a lot of objections. The risk is pretty minimal, both to the pregnant woman as well as her fetus, and the benefit seems to be quite high. In other areas of maternal fetal medicine, that calculus becomes much more complicated. As was highlighted, to undergo a sort of procedure in order to gain access to the fetus is no small routine surgery. Even a cesarean section by no means is small or routine. These women can have multiple complications, both immediately, infection, whatnot, but also it raises significant risk in the future for rupture or of the uterus in subsequent pregnancies. So there is some work that's coming out, specifically the group who did the MOMS trial, which was the prenatal surgery for spina bifida, is looking at the data and how moms do in subsequent pregnancies, but it is certainly not without risk. And so to do this sort of calculus where you tell a pregnant woman, many of whom would do almost anything if they knew it would benefit their fetus, that we have something available to you, has raised some concerns by many people that you're in essence taking advantage of this woman's altruism or offering something that the risks are just too high. On the other hand, some people, including Annie Janvier in Montreal and others, have written that that sort of paradigm where we paternalistically withhold procedures from a pregnant woman because we find the risk to be too high is also not appropriate. So balancing the sort of risk stratification is so very difficult. You can imagine in a difficult situation, you're meeting all these new providers who are going to talk to you about the risks of an exit procedure, what are the potential risks of prematurity, what are the potential benefits if we do said procedures, and numbers are being thrown out. Ultimately, we just don't know real well. There's so much gray area. There's so much uncertainty. If the child's 26 weeks, 27, 30 weeks, things become clear. But there still remains this gray zone where we're plagued by the tragedy of uncertainty. And that's where I think I quoted Dr. Lantos in some of his work on prematurity, which I think is really helpful. Again, resisting the temptation to always wanting to do everything in the hopes of saving that one child, and yet promoting a lot of suffering, a lot of morbidity as well. So in regards to that aspect, obviously there's going to be a lot of work that needs to be done, really defining the risks and benefits so that a pregnant woman could have an educated, like a truly educated, informed decision. But obviously there's a lot of factors that go into that. And there's people arguing that we shouldn't offer those sorts of decisions to women. I believe that if it can be done in an uncoercive way, where the woman is given the best information she has, I think there is a certain level, a threshold of risk, so to speak, that ought to be permissible. Certainly we permit people to take risk upon themselves, for example, to donate a kidney to a loved one. So there are social bonds that draw us to each other, and certainly the maternal-fetal bond is strong. So, but finding that threshold and that line, as you allude to, is incredibly challenging. As far as stratifying, you can imagine there'd be a whole range of neonates that this could be applied to. Just a premature infant to a baby really sick. For example, some children who have a hernia or a hole in the diaphragm, congenital diaphragmatic hernia, can have really severe and poor lung development. People have floated around this sort of technology as a bridge to allow the lungs to develop more. Again, you can apply this to sicker and sicker populations, and you may sustain life. You may have increased survivability, decreased mortality, but the trade-off with that could be severe morbidities. So a lot of this will have to be carefully thought through in terms of which fetuses would be candidates who would actually benefit as opposed to have significant risks.
They encounter is how to navigate the fetuses. And so while they're, I would say that the very premature infants, there's a lot of uncertainty. They're more certain when we have, for other like anomalies or genetic conditions because we have population data. And as we sort of talked about, it's very hard still to stratify this. The gestational age cutoffs are not as good indicators of where viability falls as some other characteristics like sex or weight or virality of the baby or babies. And I'm sort of curious to think about how a trial for this could be integrated into counseling in a way that made sense. Like which babies could be chosen, how could they be chosen? I think right now antenatally, we will say there's a range of what we expect could happen. It's very hard for us to know. And even with the sort of characteristics to help us stratify antenatally, there are many other factors that we don't account for. For example, sepsis. I would imagine being delivered into a sealed bag that's still being covered in bacteria probably doesn't make your odds great in your artificial placenta. I don't know anything about it, but I'm sort of calculating. And we often don't know if babies are going to be septic when they're born in Wisconsin or not. And so sort of the idea of weighing, the probabilities that we have that still have a lot of uncertainty against the really uncertain uncertainty, and how you can sort of explain these different kinds of uncertainty. Do you go with the 50% survival, 50% intact sort of known probability risk versus the completely unknown? How do you present that fairly? It's like, who do you recruit for whom that's a fair trade-off?
Yeah. Those are great points. And some of my work has even looked at how parents understand risk, factors such as some of you might be familiar with things like emission bias, how we present risks and benefits and how that's therefore interpreted and then eventually results in trial participation or choice of undergoing said procedure. Obviously, there's enormous variables here, and part of the problem and part of the questions from the FDA is just that, defining who is the population that you would start with. Obviously, for a trial like this, they're going to start with a population that is kind of right on the cusp of viability, has the greatest morbidity risks, and it's going to be a very small trial. They're going to be watched very closely. Factors that you mentioned, things like sepsis, things like that, obviously have been worked out or they're trying to work out in the animal models, use of antibiotics, all these sorts of things. But yeah, you raise a lot of excellent points. I'm curious how you think a trial like this might differ than the conversations you have with families, for example, of going on to ECMO or not versus palliative care. What sort of things just from this presentation stick out to you might be additional challenges beyond those difficult conversations?
what the technology is and sort of what it can and can't do before it agrees to participate in a research trial. And I think that that's, a bit different from sort of agreeing to a well-established therapy that we agree would be ethical to offer in the situation. There are some similarities in sort of where do the lines draw and what is offered and not offered, how are parents informed enough to communicate to their child about what to do clinically. But I think that research is a different layer of informed participate. And I would hate to imagine that the trial started, the mom went through an exit procedure, this happened, an unexpected complication that we didn't even know was happening even if it did. And she said, boy, at 23 weeks, I could have had a 25% chance of an intact child. I had no idea it was going to be catastrophic. I mean, look at the support trial, right? People thought that they understood that, and then they came out and they said, boy, I didn't understand that being a low oxygen group could kill my kid. And they were angry about it. And that seems pretty well explained to all of us who, were in, from a research end, thought that this trial, was understood. And so I just think it's really treacherous going forward with it, trying to make sure. And, I feel like you said that we should do it in only the smallest and the thickest when you look at 23 weeks. And we were supposed to take 22s here. We had a 22-week boy with no steroids go home, no oxygen. Seems smart, if I have that behind me, it's hard for me to say, hey, but don't worry, put your 23-weeker on here,
Well, right, but if I could jump in here,
Yeah.
I think it would be different for you if that 22-weeker was born, got maximal therapy, and then was failing.
Yeah.
And you basically have the same scenario like putting the patient on ECMO. The same scenario, except that you don't have the wealth of experience and data to say, well, with ECMO, you had an plumbing aspiration, vitals will be 90%, you think you're going to be on for a week or less, and your chance of bleeding into your brain is X, right? You can say we have this novel technology, but at least then you have this risk stratification. I mean, I think if I heard you correctly, I actually totally disagree with that philosopher who said something about paternalism, that like, well, give them the info, let them decide. I think you made a very good point working in fetal surgery. The moms are frequently all do anything. And I think it is our job. I don't think it's paternalistic. I think it is our job to really very carefully provide like really extreme informed consent and also, really give them as much of the risks and benefits. I mean, when this is the way your iteration, the CHOP iteration of the artificial placenta is a fetal surgical intervention. And 30 years ago, Mike Harrison in San Francisco and a group of people working in that field had a number of criteria. And again, one of them is understanding the natural history. So it's different than premature. You have, okay, we could all maybe agree. Let's say we knew this artificial placenta worked great and had no problem, which is unlikely, right? I mean, ours is going to work great. Let's say we knew it worked great. I could get maybe 22-weeker where their outcomes are pretty good.
Yeah.
Right. So maybe, you know what I mean? Like maybe then gestational age alone, you would say, look, we have this like artificial womb, we just transfer from womb to womb, it's gonna be great. Like maybe. But we're not really, and it probably may not even work for mechanical. I'm not gonna get into it, but
Sure.
there's a lot of mechanical constraint that only the anticoagulation thing is solved with heparin bonded circuits. Like, I think there's still some science to be done here. But even assuming it works really great, I think that's a big problem of, then you're going to be counseling on
considerations when we get to humans. At what point might we change tracks or look to get that approval in advance?
Yeah, that's a great question, practical question, I guess. I'm now obviously not at Penn, so I'm not as involved with all of those outworkings, but from my time there, already very early discussions were taking place with the FDA. They were getting involved very early to try to anticipate issues, both from the science as well as some of these ethical concerns. I'm not sure the model here at Penn, they actually have a special IRB that's focused on kind of maternal fetal issues because I guess their clinical excellence in that area, they felt that it'd be important to not simply have IRB oversight, but actually IRB oversight composed of individuals who, like many in this audience, have expertise in these sort of areas. So those individuals have been involved already. The extent and how formal it's been, that I can't tell you, but I know there's been early conversations trying to sort out some of these sort of things. So maybe just to recap a couple of the fantastic points from this discussion. One would be, again, which makes this so much more difficult is that it is research, right? And so things like therapeutic misconception and this whole array of topics within research ethics adds a layer of complexity to it, a layer that you, many in the audience, have thoughtfully articulated. One point, maybe just for clarification that could help, also in terms of selecting who could participate in a trial, there's simply just anatomic limitations. So you can imagine that to attach the fetus to this device, you need to cannulate the umbilical vein and arteries, and that's incredibly difficult, and they're very susceptible to spasm. They don't like to be cannulated, and also just a size limitation. And then there's issues with the pump itself and the normal pressure it needs for flow. And so there's all these also physiological limitations, which are maybe dictating who and when and where, your initial patient cohort. So it's very interesting to see, not only in the ideal world would you do it in set population, but obviously the investigators also are selecting their population on what is possible. Whether or not they should or not is another question. But really good comments. I think we probably have time for one more question.
Certainly, I am actually, excuse me, a long-time ICU nurse, so I get the draw to these like really sexy technologies, and I have no doubt that if somebody did this and was successful at it, then here at the University of Michigan, they'll get their face up on a big poster, right? So, but I can't get past your slide showing the rate of the United States and our level of prematurity in all these other countries. And so I kind of want to take my ICU and hat off, and my research facility hat off, and put on my community hat. And my response is, part of me wants to have that John Rawls original position approach of saying, if we really care about premature babies, what are all these other countries doing that are doing so much better than us? And should we put our effort into that instead of these sexy technology to help a few? I struggle with that.
Yeah, that's a wonderful point. Justice-related issues are very pertinent in these sort of interventions. Obviously, this technology is very, very expensive, no question about it. And are there ways that we can help the rate of prematurity, for example? One thing that's been interesting, a lot of public health researchers have noted that in the US, our rate of prematurity continues to go up despite a lot of efforts and despite a lot of money trying to solve that problem. And a large reason is because technologies where we earlier and earlier get more and more diagnostic information, and then we have kind of this imperative to do something about it. And so we do things like fetal surgeries, some with benefits, some more questionable. And so we're doing more and more, kind of contributing to this problem of prematurity. So on the one hand, it's exciting, and there's this imperative to advance, to do more, to try to help these fetuses with anomalies. but also we have to confront limitations, financial limitations, societal limitations, and it's difficult to know when to do nothing at times, to let nature kind of take its course versus intervene. So really good point.